Bariatric surgery is not new to Centennial. It's been performed at Centennial for probably more than 30 years. But when I started the program in 2000, I realized the importance of integrating all aspects of care, to have a comprehensive program to treat all aspects of the bariatric patient. Because in addition to the physical issues and the metabolic issues, we also have the psychological issues that play into obesity. And to maximize success, you have to address all of these aspects of care.
We have 3 dedicated surgeons who care about the patients, who care about this disease. We're not a factory trying to churn out a ton of cases every year. We're really trying to improve the lives of these patients. Our program itself, we feel, is special and set apart from other programs. We have wonderful dietitians on staff, exercise physiologists, we have support groups, we have psychological aftercare programs to help the patients deal with the emotional side of eating. We like to see all patients come through our informational seminars, and it really goes A to Z about bariatric surgery and what it entails, what the risks of the surgery are, what the outcomes are, and what to expect long term.
So when you have bariatric surgery at Centennial, the dietitian's consultation, the exercise physiologist's consultation, our psychological aftercare program, it's all included at no additional charge.
We're a center of excellence with the American Society for Metabolic and Bariatric Surgery, which is the National Bariatric Surgical Society. We're centers of excellence with many insurance programs. But that when you're a center of excellence, that means you have to meet the highest criteria and that you have to have excellent results, minimal complications, and follow up and take care of patients long term. From the check-in area in the admissions department through the holding area in the surgical department to the operating room, and even on the floor after surgery. Special beds, special bathroom accommodations, special gowns, and all these things make it possible for patients to have their best, safest experience with bariatric surgery here at Centennial.
The sleeve gastrectomy procedure has become one of our more commonly performed procedures here at Centennial. And here to talk to you a little bit more about the sleeve gastrectomy and go over the potential risks, benefits, and complications for that procedure is Dr. Douglas Olsen.
A common question that patients often have who are considering surgery for the management of their weight problems is, why don't I just try dieting and exercise? Maybe I can do it without that dangerous operation. Studies have demonstrated, however, that less than 4% of people who are morbidly obese can successfully lose weight and maintain that weight loss through conservative measures. To understand this, one needs to simply consider obesity as a disease. And as with any disease, there's a variety of severities of that disease. People who suffer from very mild obesity can control their disease through simple diet. But as that disease becomes more severe, you need a more severe treatment protocol. To better understand this relationship, let's use the disease of diabetes as an example. There are people with very mild forms of diabetes that can be simply managed through diet alone. But as that diabetes becomes more severe, we have to add stronger treatment protocols. The first would be to add what we call an oral hypoglycemic, or a pill. As the disease becomes more severe, we might have to add a second or a third pill, but ultimately we end up having to add an injectable form of medicine called insulin. And then as the disease of diabetes becomes even more severe, we often have to resort to what's called an insulin pump, a mechanical device that gives a continuous infusion of insulin to be able to manage that individual's diabetes. And just as it would be ridiculous to consider managing severe diabetes through simple diet, so is the same for severe obesity. Simple dieting and exercise may work for someone who has the lesser form of the disease, but when somebody suffers from the more severe form of the disease that we call morbid obesity, we need a much more severe treatment plan. And that plan is surgery.
We know that obesity is a major health problem, not only in the United States, but worldwide. As we can see from this map of the United States, only a few states, maybe 25% or less, have somewhere between only 20 and 25% of their population being obese. Maybe another 25% has somewhere between 25 and 30% of their population being obese. And probably another quarter of the nation has 30% or greater than their population being obese. Tennessee used to be ranked in the top 5 in obesity, however it is now approximately 16, but obesity remains a major health problem in our state of Tennessee. Obesity is really determined by body mass index. When we talk about obesity, morbid obesity, we need to have a means of measurement. Patients are considered obese if they have a body mass index of 30. That's about 50 pounds over your ideal weight. They're considered to be morbidly obese if they have a body mass index of 40 or greater, and that's about 100 pounds over your ideal weight. On this slide, we can see a progression from obesity with normal body mass indexes in the range of 20 to 25. Patients that are slightly overweight and would be candidates for medical therapy have a body mass index between 25 and 30. Definitely patients need medical therapy and start looking at possibly different types of surgical therapy when their body mass index approaches 30 and 35. But it's when patients, maybe I shouldn't say that, I've probably got in that surgery part too quick. Let's just start this segment over.
Okay. You want to recite, start the whole thing, or what?
We'll probably just start with the BMI part.
Yeah, we'll just start with the BMI part.
Good.
Okay. As we were talking about, obesity is a very serious health problem in the United States and our state of Tennessee. So we need a means to measure obesity. And that's what body mass index does. It takes height versus weight, converts it to a number, and allows us to have patients of different heights, different weights to see if they have similar degrees of obesity. When patients have a body mass index between 20, 25, they have a normal, healthy body mass index. Patients start to get to be a little overweight, they may have a body mass index between 25 and 30. When they get a body mass index that exceeds 30, which is about 50 pounds over your ideal weight, patients need to strongly consider medical therapy for the treatment of their obesity. But when patients reach body mass indexes of 35 and greater with comorbid conditions or body mass indexes greater than 40, even without comorbid conditions, we need to look at them as being potential surgical candidates.
I had my surgery at a very early age, considering the time of which I had my surgery. I was 26 at the time, and I come from a family of obese individuals and have lots of complications: diabetes, high cholesterol, high blood pressure, heart disease, and I had tried every diet. I hit 200 pounds when I was 12 years old, and I never left.
The ideal candidate for bariatric surgery is a patient that has body mass index greater than 40, medical conditions related to morbid obesity, failure of medical treatment, dietary behavior modification.
I had never had surgery before. This is my first experience ever having anesthesia or having surgery. I had a ton of support from other bariatric patients, from the faculty here at Centennial, and from my family as well.
She continues not to follow up so much with the physician's office because she is doing great and not having any medical conditions, but she does continue to come to a support group, meet with the dietitians and exercise physiologists and group follow-up.
The aftercare support groups here are phenomenal. It really means a lot to the patients to be able to sit in a room with people who have been where I have been and people who have experienced the same things that I have. It's also nice on the post-op side to be able to come back and to support those patients that are at an earlier stage in their journey, and to be able to pay it forward to those other patients.
Paula had great results with her gastric bypass, and it was the best operation for her after we had had our initial consultation. She had very good weight loss, and I think Paula's also had plastic surgical procedures to remove some of her excess weight. And so as she has continued to keep her weight off, she has remained active and healthy and off many medications that she was taking prior to surgery.
I went ziplining in Mexico, and I looked at the sign and thought, 2 years ago, I would have exceeded that weight limit and would have to sit here while everybody else had fun. So it has opened up a whole new world and a whole new life that I never would have known before.
So Dr. Dyer just talked about morbid obesity being the point to where it becomes clinically, I don't want to say that. So Dr. Dyer just talked about the definition of morbid obesity, which is the point to where the obesity is causing serious consequences on your body. These are called comorbidities. The most common comorbidities that patients that we see once you become morbidly obese are hypertension, sleep apnea, diabetes, high cholesterol, arthritis, infertility. And these diseases may not be the first thing that brings patients into our office. A lot of patients are coming because their quality of life's affected. They're having a hard time traveling with their families, having a hard time playing with their children, and having a hard time participating in sports and things like that. And so quality of life is probably one of the biggest things that brings patients in to consider weight loss surgery. But then we're seeing a lot of people being referred from their primary physician because of these comorbidities. Patients don't quite relate these diseases to life-threatening consequences down the road. When you're about 100 pounds overweight or greater, it does shorten your lifespan 10 to 15 years in relation to these comorbidities. Diabetes, sleep apnea, high cholesterol, hypertension cause heart disease and heart attacks. So one of the benefits, many benefits of weight loss surgery is when you lose 50 plus pounds out of 100, over 50% of your excess, these medical conditions go away completely. Most patients leave the hospital not needing their diabetic medicines. Patients come off their CPAP machine within 6 months. Their hypertensive medicines are tailed off in 4 to 6 months. Arthritic medicines usually are not needed anymore. And it's just remarkable to see how losing that weight really resolves these comorbid conditions and improves these patients' quality of life. So I'd like to talk about lap band and duodenal switch surgery. These surgeries, I kind of look at them as a sort of a timeline or a strength of how these procedures fit in, the band being the sort of the lightest procedure towards helping you with your appetite and your portion control and your weight loss journey, versus duodenal switch being our heaviest procedure, meaning the most aggressive surgery, the one that helps you lose the most weight. Gastric bypass and sleeve sort of fit right in the middle of those spectrums. Lap band surgery evolved really from trying to, our original surgeries we worked with were gastric bypass and vertical banding gastroplasty for many years. We still do gastric bypass, and vertical banding gastroplasty has kind of faded. And what came out of that procedure was something towards something less invasive, something less permanent in the gastric banding procedure. The gastric band is a silicone device. It's pretty much inert. It really can't, you can't be allergic to it. It's not caustic to your abdomen or your stomach. It is wrapped around the upper part of your stomach and locked in place. There's a catheter that hangs loose in the abdomen, and attached to that catheter is a port, or we call it an access device. And that device is placed on your muscle layer between your skin, sort of below your skin, and then we have a fat layer, then we have muscle, and that's where the port is placed. And the way the band works is you come to the office after you've healed from your surgery, and we access that port, we put a needle down into it, and we put fluid into that port, and that fluid then tracks back up the catheter and goes into the band, and inside the band is a balloon that starts to inflate, and it starts to make the opening between your esophagus and your stomach smaller, smaller, and smaller, so that you then have to take your time, chew your food better, slow down. As such, your overall calorie intake is less. It also helps to start to control your hunger. And so then you start to space out into 3 small meals a day to help control your calories, which then allows you to start losing your weight. The surgery is very straightforward, very few complications at the time of surgery. The surgery is outpatient. You do go home the same day. And the recovery with the surgeries is about 5 to 6 days. You're really kind of back to most activity and really back to work in about a week. The risk of the surgery up front are pretty minimal. You could have risks that go along with any general surgical procedure. You could have a bleeding complication, very uncommon, less than 1 in 1,000 cases. You could have a wound infection, 1% or less, pneumonia, 1% or less. You could have blood clot in your legs, 1% or less. So all in all, it is a very safe, straightforward procedure to have up front. However, the band does have some long-term risk that you do have to be aware of, and you do have to take into account when you're deciding between these procedures. The main problem or the main disadvantage with the band is that it is a foreign device, and as such, this foreign device is going to have a number of them that fail. It's probably upwards of 10 to 12%. If you read the literature, some people will quote 6%, some people quote 15%. I try to talk in the middle, about 10 to 12%. And the main complication is called a slippage, and the way a slippage happens is our esophagus is pushing food through this band. Normally our esophagus has no resistance to get food into our stomach, and now you put this band on it and you make it tight. And the esophagus has to work overtime to get food into that stomach, and it can just start creating a wear and tear area, and it starts to push that band down around a bigger section of stomach, starts to pull stomach above it. The band gets caught and starts to strangulate that piece of the stomach, and you get to where you can't tolerate your foods, you can get to the point where you can't tolerate liquids, and that's a surgical urgency to get that in and get the band taken out. And obviously that's a bad complication, because then you've required another surgery. You've also then lost the band, and at that point you don't have a weight loss tool to help with your hunger and your portion control. And so then, that's the thing you have to consider. You can go on to have other procedures after a band has been removed. A little bit more difficult to get insurance to cover it at that point, and they are more risky than having that particular procedure the first time around. So that's kind of how banding works. It is a slow, gradual process in its weight loss. We do put fluid into the band. These adjustments where we put the needle into the port and put fluid into that band. So how the band works is, we talked earlier about how you get the needle into that port and do these adjustments. These adjustments, you need about 4 or 5 of these adjustments for that band to really start helping you with your portions and your hunger. We can't really do the first adjustment until you're about 6 weeks post-op. Then each adjustment is about 6 weeks apart. And it takes about 4 or 5 of these adjustments, so about 6 to 8 months to where the band really is starting to help you with that hunger control and the portion sizes. So it is a more gradual, a little slower weight loss compared to some of the other procedures. Most patients lose about 40 pounds out of 100 in the first year. They may lose about another 10% over the next few years. Overall, the long-term average is about 50 pounds out of 100 for the gastric band.
Sleeve gastrectomy is the newest of the operations that we've added to our armamentarium of procedures that can be used to help people in their struggle with obesity. Although I say it is a relatively new operation, it's actually been around for more than 10 years, having come from a much larger operation called the duodenal switch. We learned, however, very early that the operation of sleeve gastrectomy by itself is a very appropriate procedure for helping people lose significant weight. In the sleeve gastrectomy, we are removing the outer 80 to 90% of the stomach, leaving a very long, narrow stomach tube that is approximately the size of my index finger. And this creates significant restriction, allowing people to feel full rapidly after a very small meal. But as with the gastric bypass, the sleeve gastrectomy also has a hormonal influence on hunger. By removing the outer portion of the stomach, we effectively reduce the body's ability to make an appetite hormone called ghrelin, thereby decreasing baseline hunger. So through a combination of hormonally decreasing hunger and the effect that we receive by satisfying the hunger through a very small meal, this operation is very effective at helping people to lose significant amounts of weight. Most people can lose between 50 and 80% of their excess body weight, a weight loss that is very comparable to that expected with the gastric bypass procedure. The real benefit with the sleeve gastrectomy comes about by the fact that although we're making the stomach smaller, we don't effectively really change the anatomy. There's no intestinal rearrangement as we have with the gastric bypass. Despite this, we still achieve similar results to the gastric bypass, since we not only create restriction, but also have a hormone influence on the reduction of hunger. The weight losses are very comparable to the gastric bypass, but we achieve this without changing the anatomy. This, in the long run, decreases potential risks with malabsorption of vitamins and minerals, and also reduces long-term issues of what we call an internal hernia. The risks of the sleeve gastrectomy not only include the generic risks that go along with any operation, things such as heart attack, stroke, bleeding, infection, blood clots, but it also has a specific risk related to leakage from the long staple line that we create as we remove the outer part of the stomach. This staple line can break apart, letting stomach juice leak into the abdominal cavity, leading to severe infection, what we call peritonitis. Fortunately, this risk is short-term. That seam heals just like any incision heals, and after we get through the healing phase, the first 6 to 8 weeks, that risk essentially goes away. Even if a leak does occur, the vast majority of the leaks, better than 95%, will heal through conservative management, meaning no surgery required. It would require hospitalization so that we could feed you through your vein, avoiding having to add any additional food that could leak. We'd have to treat you with some antibiotics, but generally, given some time, the body will heal that leak on its own. Other than for leak, there are very few specific complications associated with a sleeve gastrectomy. There has been a description of an obstruction in the sleeve itself that one can kind of think would be akin to a garden hose being kinked in half, but this can generally be managed conservatively either through endoscopy, where we simply straighten the kink, or by anchoring the sleeve at the time of surgery to help avoid this kinking from occurring in the post-op phase. Therefore, in the long run, the sleeve has very few long-term issues that makes it an even more attractive procedure compared to some of the other operations that we have to offer. The ultimate risk with any operation is mortality. As far as the sleeve gastrectomy is concerned, the operative risk reported across the country is 0.12%. And even though people talk of bariatric surgery as being high-risk surgery, this risk of mortality is actually less than the risk of dying from a commonly performed procedure called cholecystectomy, or the removal of the gallbladder. Jane, you've done well with your surgery. As I understand, you've lost about 150 pounds and have kept that off for over 4 years. Is that correct?
That's correct.
Before you had the surgery, did you have any success with diet and exercise?
No, not at all. I have tried every diet known to man, and I didn't succeed, obviously. And I knew that there was something I had to do for my health to get the weight off.
What was it that prompted you to seek out the surgery and more specifically come here to Centennial for your operation?
I knew that I couldn't do it totally on my own, that I needed help from something besides the fad diets. And I had heard a lot of positive things about Centennial from other patients, and I knew there was the comprehensive bariatric center, and I knew that I needed all the support that I could get in making the decision to have the surgery.
Now, we often talk about surgery being nothing more than a tool. Even at 4 years, having lost 150 pounds and doing as well as you have, do you find that you still have to work at it?
Every day, it's a one day at a time fight with obesity, even having surgery. It's a lifestyle change, and it's daily. I have to be accountable for everything that I eat and what my exercise consists of, which I love exercise now. You know, it's changed my life, the surgery, so it's made me a whole different person inside out.
So what is the surgery actually doing for you today?
It's a tool. It helps me. I don't eat as much as I did 4.5 years ago. It keeps me on track. it's a tool that helps me maintain my weight with lifestyle change.
Jane, earlier you were mentioning how every day is a struggle. You continue to struggle, you continue to work with your weight maintenance. Where do you think support group factors into that struggle?
Well, support group was very instrumental in me making the decision. I actually started attending support groups before my surgery, and it was very instrumental in me making the decision of which surgery to get and actually giving me the support I need to go through with the surgery, because it's quite frightening. Any kind of lifestyle change is quite, scary. And support group is just a great tool, as well as the tool itself, in maintaining your weight and keeping you accountable and interacting with other gastric bypass patients or weight loss surgery patients. And actually, one of the support groups, I actually demonstrated Zumba, and that was I would have never dreamed when I was attending support groups 4.5 years ago that I would actually be a person up doing something. I was just wanting the surgery and didn't know if that was ever going to happen, but it's really, support groups have really brought me as far as I am with my success, I feel.
Kind of helps you stay the track and helps you get back on track when you maybe have had a little bit of a slip.
Exactly. And you interact with other patients, and you actually now, when I go to the support group, I see other women or patients, future patients that had the same questions that I had, before I decided to do it. So.
As I understand, you recently got a job modeling.
Actually, I want to be modeling for a photographer, and he doesn't know anything about my weight loss surgery. He's just interested in photographing me, and so I'm very excited about that new part of my life, I guess. So, and I would have never been able to achieve anything that I have achieved unless I had weight loss surgery.
That's great.
Yeah.
Long-term wise, though, have you had any complications or issues associated with the surgery that you had?
Not at all. I've done very well. I've done everything pretty much by the book, though, as far as my vitamins and things that I need to do daily. And so I haven't had any problems whatsoever.
And you had the gastric bypass, is that correct?
Yes. Weight loss surgery is a wonderful tool, and I'm glad I did it. So.
As I understand, you've had some communication with Carney Wilson?
Actually, yes. I put a picture of me. I'm on Twitter, and she's following me, and I'm following her, and just kind of expressed to her that I'm on the same journey she's on, and she responded in saying that I looked great and thought I had done a wonderful job. So it was awesome to get that. So it was like, yes.
Well, you've done well, and we're really proud.
Well, thank you so much.
So this operation is gastric bypass Roux-en-Y. It is a combination operation in that it has mechanisms of both restriction and malabsorption. Actually, this is an operation that's been around about 40 years as an open surgical technique, and it's been performed laparoscopically for the last 20 years. It's probably one of the most frequently performed bariatric surgical procedures in the United States, and one we still frequently perform at Centennial. Our greatest emphasis at Centennial is to perform gastric bypass with laparoscopic or minimally invasive techniques. We're successful probably 95% plus the time. Rarely do we have to do open surgery, maybe 5% or less. But we do the same basic inside operation whether we do it laparoscopic or open. We're going to create a very small upper stomach pouch. We totally separate that pouch from the lower stomach. Then we create an intestinal limb or a roux limb. We take it up and connect it to the stomach pouch. So that allows food to go from your mouth, the esophagus, stomach pouch into the small intestines. The large lower stomach is totally excluded from the flow of food, but it's still a live tissue. It still makes digestive juices. Those digestive juices can flow out of the stomach through the pylorus into the duodenum. At the time of surgery, we reconnect the two intestinal limbs, so that allows foods and digestive juices to mix together so that food can be digested and absorbed in the lower small intestines. Patients that have gastric bypass have it performed laparoscopically. They are generally in the hospital maybe 2 or 3 days. They go home on liquids for about 2 weeks after their surgery. Then they gradually advance to pureed foods, soft solid foods. We feel that follow-up is very important. It's very important that you follow up with the doctors, dietitians, exercise physiologists, attend support groups. We firmly believe that all of these modalities go together to allow patients to have their greatest success following gastric bypass. As far as benefits of gastric bypass, patients tend to feel full following a small meal. They have dramatic reduction in hunger. They also have greater weight loss than patients that undergo pure restrictive operations. Our experience with gastric bypass is a little longer, as it's been around, as I said, for 40 years. Patients may get dumping syndrome. We really consider dumping syndrome to be a benefit and not necessarily a complication, but dumping syndrome can occur anytime we bypass the pylorus of the stomach or remove it, where we have changes in blood sugar, insulin levels, fluid shifts into the small intestine, so it can make you feel bad, maybe sweaty, nauseated, vomiting, occasionally having diarrhea. Gastric bypass is a non-adjustable operation, so we don't have a port or a band that we can add or remove fluid to adjust. We really need to be considering gastric bypass as a permanent, non-reversible operation. Technically, it could be reversed, but is an extremely high-risk operation to reverse. Certainly gastric bypass, as with any of our other operations, has the potential for complications. We generally break complications down into early complications, which occur early in the postoperative period, and later complications, which may occur even years after your procedure. Early complications are complications that really can occur with any major surgical procedure. One of our most serious complications with gastric bypass would be the potential for leak. That usually occurs where we make our new connections between the stomach pouch and the intestine. The leak rate is 1% or less, which is really very low, so it is extremely rare that we have to reoperate for leaks. Even if a leak is detected, probably 70% of those leaks heal without additional surgery. There's a 1 to 2% risk for blood clots. The blood clots that we're talking about here are clots that develop in the deep veins of the legs. They break off, they can go upstream in the vascular system to the lungs and increase the risk for surgery. So we want to reduce the risk of clots. The things that we do to reduce clots around the time of the operation, we're going to give blood thinner injections. We use leg pumps called sequential compression devices, and we get patients up walking and moving early after the operation. Another potential complication with gastric bypass, as with any major abdominal surgical procedure, is pneumonia and pulmonary problems. Probably a 1 to 3% risk for that particular complication. Things that we do that reduce the risk of pneumonia. We get patients up walking and moving early after the operation. We even have patients walk the night of their surgery. We use a device called an incentive spirometer, and we encourage them to breathe deeply and cough following the procedure. Small risk for infection, that's in the range of 1% or less. We give antibiotics in the perioperative period to reduce the risk of infection. Small risk for bleeding, probably in the range of 1 to 2%, so low that we don't anticipate giving blood transfusions or even set up blood to give blood transfusions. And the mortality rate, very low following gastric bypass, in the range of 0.5% or less. As far as late complications are concerned, maybe one of the most serious late complications would be stricture, maybe a 5% risk for the development of a stricture. That would be where we get a narrowing, where we've made the new connection between the stomach pouch and the intestines. Or as it heals, it scars down, it gets so tight that food can't empty out of the stomach into the small intestines. And so that would be a stricture or stenosis. To treat that, we would perform a flexible endoscopy, put a balloon across the area of narrowing, expand that balloon, and that generally effectively treats stricture with only 1 or 2 applications. There's small risk for vitamin deficiency in the range of 5 to 10%. pretty rare. We do recommend that all patients following gastric bypass take vitamin supplements. Usually it's 2 chewable multivitamins with iron daily, calcium supplement daily, vitamin B12 on a regular basis. We also know that many patients are vitamin D deficient after surgery. We also know that many patients are vitamin D deficient even before surgery and may need vitamin D supplement following their operation as well. Gallstones can occur following gastric bypass, probably in the range of 20–25%, but gallstones can also develop with any rapid weight loss, whether medical or surgical. We don't routinely remove gallbladders when we do laparoscopic bariatric surgical procedures, but as patients lose weight, if they start to develop complications of gallbladder disease or symptoms of gallstones, we do the appropriate test, usually an abdominal ultrasound. If we detect gallstones at that time, we can still many times perform gallbladder surgery laparoscopically as an outpatient. Another late complication of gastric bypass can be the development of internal hernia. That probably occurs in 2 or 3% of patients. Internal hernias can occur anytime that we reroute the intestines, or we take one limb of the intestine up to connect it to that stomach pouch. We have some openings or defects along the vascular supply to that intestinal limb. We close all the defects at the time of the initial surgery, but sometimes as patients lose weight, some of that intra-abdominal fat melts away and defects can reoccur and trap the small intestines. If the intestines would get trapped, cause a blockage, surgery would be necessary to treat that complication. Another potential late complication would be osteoporosis or decreased calcium in bones. We do recommend calcium supplements regularly for our patients. We also do periodic bone density scans to make sure that patients' bones are maintaining adequate calcium and adequate strength. Another potential late complication would be weight regain. Statistically, there's maybe a 10–15% weight regain following gastric bypass. So this is not totally unexpected, but we feel that as long as patients continue to use their operation regularly as a tool, eat small meals, not snack between meals, exercise and follow up regularly, that they'll be able to maintain their weight loss long term.
I was almost 300 pounds. I was miserable. I'd just gotten a really bad report from my primary care physician. The decision to have the surgery was just like, okay, this is the only thing I think will ever work for me. This is my last ditch hope to ever regain my health.
But if somebody has the disease that we refer to as morbid obesity or severe obesity, the ability to use normal measures to gain control of their weight are beyond their grasp, and so they need more help. There's 4 primary procedures that make up the mainstay of all of the operations that we perform. And you can kind of think of these procedures in a hierarchy, with the adjustable gastric band being at the low end, with the sleeve gastrectomy being the next procedure up on the ladder, followed by the gastric bypass. And then the ultimate of the operations would be the duodenal switch. And much of it is about controlling appetite.
It's been the most wonderful tool. I've been able to lose the weight and, maintain the weight for, 9 years now.
We take a very strong interest in making certain that during the post-op phase that they are properly educated on how to utilize this new tool that we've given them. Because that's what these surgeries are, nothing more than tools.
I was very good about attending support groups. It's so important to have that kind of support.
And it's this new lifestyle change that ultimately allows them to lose weight and keep that weight off.
So duodenal switch is at the other end of the spectrum of helping you with, lose your weight. It's sort of our strongest procedure we have. Like the band evolved from sort of gastric bypass procedure trying to get something less invasive. The duodenal switch evolved from gastric bypass surgery and trying to find a procedure that helped patients that either didn't lose enough weight with their gastric bypass or that gained a significant amount of weight back after the gastric bypass. And the anatomy for the duodenal switch, the stomach anatomy, the way we make the pouch with a switch is different from a bypass. The pouch is more long and slender, and it was made that way to lessen the risk of some of the gastric bypass pouches where they got marginal ulcers. It also tried to eliminate dumping syndrome. Some people felt like dumping syndrome was not a good thing in some patients. And so all in all, the duodenal switch stomach anatomy to help your portions and the appetite part of the surgery is a long, narrow tube. And then under that narrow tube, the intestines are rerouted dramatically so that your food only goes through about 40% of your GI tract. And what that does, it takes away some of that calorie absorption of those extra calories you eat. Mainly it works with fats. It doesn't absorb fats very well from the diet. So if you've got 400 or 500 extra calories in your diet from fatty foods, basically that's taken out into the stool and you don't absorb those calories. It is a more aggressive surgery. There's a lot of surgery involved. It is the hardest procedure I do. It is inpatient. You do stay in the hospital 3 to 4 nights. It takes me about 3 to 4 hours to perform the surgery. So it is more complex, as you can tell. And the complications of duodenal switch surgery are more profound. When you're dividing stomach and reconnecting, you've got complications of that can occur. The main risk there is what's called a leak, where the staple lines have to heal together in the first 10 to 14 days. If they don't heal, you can leak out infectious fluid, get an abscess. We have to get in and manage that with putting a drain in that area and getting you on nutritional support to overcome that complication. Other things that can happen with switch, just like with other procedures, you could have a blood clot in the legs, you could have a bleeding complication, pneumonia, wound infections. Those are higher than comparing it to a band, even higher comparing it to a gastric sleeve or a gastric bypass, just because of the complexity of the procedure. The long-term risk with the duodenal switch are even greater because the dramatic rerouting of the GI tract that malabsorbs the calories. They also have a profound effect on how you absorb iron, calcium, vitamins A, D, E, and K, and B12 by your body. And so those vitamins have to be taken in excess over the long haul, and they have to be monitored very closely long term to make sure you're not getting vitamin deficiencies. There's also one other thing with the duodenal switch is the way the reconnection's made. Some people, it's too profound on their GI tract, and they can't even absorb enough calories or protein to keep themselves nourished. And so they have to have their surgeries altered, rearranged a little bit to make up for that. And those patients can get pretty sick in that time frame. So that's kind of an overview of the two procedures. Banding on one end being our outpatient, a little bit less invasive on the front end, but maybe long term it has definitely some invasive nature to it. Then duodenal switch on the other spectrum is our more aggressive surgery. It is an inpatient procedure. It has more upfront surgical complications, and it also has more long-term surgical complications. The gain from the switch is that you can lose greater amounts of weight and you can maintain weight better because of the malabsorption, but there is obviously a large risk profile related to that.
Perhaps the most common reason why people would shy away from surgery in helping them manage their weight problem is the chances of them potentially dying from that operation. Newspapers and magazines have talked about the high risks of surgery for the management of weight, but in reality, the mortality statistics associated with weight loss surgery are no greater than those with other commonly performed operations. The risks of a sleeve gastrectomy are reported at 0.12%. The risks of mortality with a gastric bypass less than 0.3%. And here in our institution, it's actually less than 0.2%. The risks of a duodenal switch less than 0.8%. And when we compare those to other commonly performed procedures, we have gallbladder at a 0.2% mortality, hysterectomy a 0.45% mortality, a appendectomy 0.7% mortality, colon resection 0.9% mortality, a total hip replacement 1.8% mortality, and a coronary artery bypass 2% mortality. So as you can see, the overall mortality risks of weight loss surgery are no greater and in many cases less than other commonly performed operations. Studies have demonstrated that in the long run, you stand a higher chance of dying from your obesity than you do the surgery. One study showed at 5 years, A medical weight loss group who were unable to lose substantial weight had an 89% higher mortality rate than those who underwent surgery for the management of their obesity. And that even included the risk of the surgical group dying from their operation.
Well, I had some rather serious medical conditions. I was diabetic. I had to have a hip replacement, and the doctor had told me that there was nothing left he could do for my back, that the arthritis had fused the vertebrae together, so I desperately needed to lose weight.
Well, I was very supportive of Bill because he had so many medical issues. I also had a lot of medical issues, but not nearly as severe as he did.
And one of my coworkers had been here and had a lap band procedure, and she'd lost 80 pounds in a rather short period of time. So I said, "What in the world have you done?" And she said, "I went to Centennial Medical."
I started coming to support group with Bill, and we would come at least twice a month. After about 3 months, going from saying I would never have weight loss surgery, I was all for it. Within 6 months of my surgery and losing weight, I was only on one prescription. No more diabetic medicine, no more high blood pressure medicine. So it's like a whole new world for us.
We're best friends. We're hardly ever apart. We like to be together and we like to do things together, and with our health, it was becoming more and more difficult to do anything.
I feel 20 years younger because I felt like I was 10 years older than what I am. Couldn't hardly walk. We never walked anywhere. We just didn't. We weren't active at all. We sit on the couch. And now we go to the zoo. We love to walk. We go to the rec center and work out, and we're having a great time.
My diabetes is almost totally uncontrolled. My diet alone had almost a perfect blood test the last time I saw the doctor. I feel like going to work. I feel like a new man.
Okay. So Mr. Pandit, tell me how you've been doing since surgery.
Doing very well, feeling very comfortable. I've been very pleased with the weight loss I've had so far, and this is, it's better than I thought it would be.
Well, that sounds really awesome. I know you're in the hospital 2 or 3 days. Do you remember anything about your hospital experience?
I remember coming out of surgery. I remember being up walking just within a few hours. I think the biggest thing I remember was no pain. You know, maybe a little discomfort, but no pain that I recall, and was out of there pretty quickly.
Well, very good. Anything about your nursing care or maybe the pharmacist?
Fantastic nursing. In fact, I've made sure I sent them a thank you card afterwards. They were very attentive and concerned about maybe post-op pain, and encouraging me to get some fluids in, and discussion with the pharmacist about what medications I would need and any adjustments afterwards.
Well, that really should be very interesting to you, with you being a pharmacist.
Yes, sir, it was. Very concerned about it, but glad that also someone took the time to explain those meds to me.
Very good.
And just kind of a wrap-up question for him, ask him if there's anything that he would like to encourage those that are thinking about surgery specifically to do, any advice, anything like that.
Well, I know you've been doing great since your operation, but maybe for other patients, other co-workers, may be contemplating having bariatric surgery. What advice do you have for them?
Without question, investigate it, review it, get as much information as possible. I don't know that a person would have so much success with it if they haven't found out what's going to happen to them afterwards and some of the changes they would have to make, the lifestyle changes, that is.
Well, certainly I think you're right. It's so important for patients to research the operations, be informed, and know their expectations and what's expected from them, not only from my standpoint, but from the, the dietitians, exercise physiologist.
Yes, sir.
At Centennial, we feel that postoperative follow-up is a very important part of patients' care. After your operation, we're going to see you very frequently. We generally see patients every 3 months the first year, every 6 months the second year, and usually yearly thereafter, many times in group follow-up. Certainly when you come to the office, we want you not only to see your surgeon, we feel that it's important that you follow up with our dietitians, our exercise physiologist. We even have classrooms that house support groups, and they meet weekly on a regular basis in our office, many times at noon, and also some evenings. So follow-up is extremely important. For patients to have their best possible results following their operation, we feel that it's so important that they stay plugged in. Again, see the doctors, dietitians, exercise physiologists, and attend support groups. We know statistically that patients that do stay plugged in lose more weight and they maintain greater weight loss long term.
Regardless of which procedure you have, you'll go through all 4 stages of the diet. There's 4 stages to the diet. The band patients may be on the stages for a couple days, and our sleeve patients may be on them for a couple weeks. In stage 1, it's a clear liquid stage with a clear liquid protein drink. Stage 2 is a full liquid diet with a full liquid stage 2 protein drink. Stage 3 is the blended diet, and it's blended consistency. Then you move on to stage 4, which is solid protein and low carbohydrate. One of the hardest things patients have trouble with is not eating and drinking at the same time. Go ahead and start making that change now so it's a lot easier when you have surgery. 30 minutes before you eat, stop drinking, and then 30 minutes after you eat, start drinking again. Another thing that patients have questions about is our vitamins. We actually provide the vitamins here at the center. We have them for sale for your convenience. We also have a list in your manual that states what vitamins you need and where you can purchase them.
So exercise is going to help with your weight loss. It's going to prevent any type of muscle that you may lose during the weight loss period. It's also going to help with your maintenance phase. So as we go on through the exercise and through the program, we're going to be gradually increasing. I can help you tailor your exercise. So if you have any limitations or maybe you're just getting started, I'm going to help you work around those. For instance, we could start out doing like 5 or 10 minutes and do that 3 to 4 times each day and then gradually build up from there. The benefits of exercise include things like lowering your blood pressure. It's going to help with your glucose levels, your blood sugar. You're going to increase your muscle tone, and then just overall increasing your function for your heart and lungs. So your heart's a muscle like any other muscle in your body, and we want to get that pumping more efficiently over the next few months. You're going to come in to see me at 1 week post-op. I'm going to tell you to start your exercise at that time. We'll start out like you were doing in the hospital, 3 to 5 minutes, 3 times a day, and then we'll gradually increase that. At weeks 4 to 6 post-op, you're going to come back in to see me, and from there I'll add in your strength training program. We'll do the strength training normally a couple days each week, and then you'll come back to see me normally around month 6 to 9. And then we'll just kind of see how things are going, change things up if you're getting bored or just wanting to add things in. Okay, so the point is to start out small and gradually increase. And over time, exercise is going to become part of your daily life. So we're going to change that one component of your lifestyle, and just remember that exercise always gets easier.
Before I came to Centennial and Dr. Houston, I was 335 pounds. So I had a lot of trouble if I was out doing anything outside physically, as far as being somebody that could go long distances or do things with the children. We went to Universal Studios and to Disney World, and of course the biggest thing at Universal is the Harry Potter ride, the Harry Potter theme park. And before surgery, I could not ride that ride, I was too big. Once you make that decision to have the surgery, I mean, it's a permanent lifestyle change that you've got to embrace. Having that motivator with the surgery and knowing that by doing the extra exercise, it's obviously going to increase and make your weight loss, a success. You have, the exercise physiologist here that, works with you to make sure that you're doing what you need to do. The nutritionist is certainly going to help to lay out a plan for you, what you can eat, things you need to avoid. And both of those things you have access to, even if you're not in an appointment. You can call up here and talk to them, you can email them. If you need to stop by while you're in Nashville, you can certainly make an appointment with them. That is a huge plus that you have here at Centennial. 6 months out, I've lost 145 pounds, and I was telling my wife the other night, who weighs less than that, I said, just to think that I used to carry you plus some around, I said, now I struggle just to pick you up and hold you up in the air for 30 seconds, and now whenever I hit my 1 year mark in October, my wife and I both are going down for the surgiversary. That's what I'm going to treat myself to, is riding the Harry Potter ride.
So Holly, tell us how you decided to come to Centennial.
Well, I'd heard so many good things about Centennial from other people from my town, and my good friend Cindy recommended you and Centennial.
Great. And you had a sleeve gastrectomy, is that right?
I did. I had the sleeve.
How'd you decide on that procedure?
Well, I'd struggled with weight loss since high school. Off and on, probably gained 100 and
60 pounds since high school, and I knew that I needed to do something because diet and exercise weren't cutting it.
Sure.
And I like the fact that the sleeve had less risk of malnutrition and malabsorption
Compared to the bypass surgery?
Compared to the bypass.
Sure.
Yes.
Did you think about banding, or?
I did think about banding, but I didn't see a better outcome with banding as far as the numbers and weight loss go.
Okay, great. You're also a busy mom, right? You work full time?
I do.
You do? And you stay plugged in still. How do you?
I do.
How are you able to accomplish that?
I do. Facebook, Twitter, Pinterest. We stay connected to Centennial through those, and share recipes on Pinterest of healthy food, and we have a support group on Facebook that I stay connected to Pam and everybody here. So even though I live an hour and a half away, I feel like I'm still part of the Centennial family.
Sure. Great. That's great. You mentioned Cindy helped you find us here at Centennial. That's great. Have y'all been able to stay in touch, and what do y'all do to help each other out after your surgeries?
We do. We support each other a lot through this. Cindy had her sleeve done a year before I did, and I kind of got to watch her progress through the stages and just transform majorly. She's done awesome with it, and when deciding on the sleeve, that's really one thing that helped me decide, was seeing her success and see how well she did with it. So
sure, that's a common thing we hear. People choosing a procedure because their friend had it, or a family member, or coworker.
She did really good, and she highly recommended you in Centennial.
Well, thank you very much.
Made me decide.
Great. So Holly, what advice would you give other patients who are seeking bariatric surgery?
I would advise them to definitely do their research and find out what procedure is best for them, because what works for one might not work for another.
Sure. How might they do that?
Through the internet to start with, and then I would definitely recommend going to some support groups before you decide on surgery. I did that. I went to a few, and also come to a seminar. Very informational.
Great. Hi, Cindy. How are you?
Hi, Dr. Huston. Great.
Good to see you. You had surgery in 2010, right?
I did.
Wonderful. Tell us about what procedure you had, how much weight you've lost, and how it's changed your life.
I had the gastric sleeve done, and I've lost 145 pounds.
Wow.
And it's
That's
changed everything. My blood pressure is down. I was borderline diabetic before. Now my blood sugar is completely normal.
Wonderful.
I can exercise. I can do anything I want to that I couldn't before. So
That's great. I hear you're having plastic surgery coming up.
I am scheduled for plastic surgery in 2 weeks.
Now, how did you come to that decision, and what process did you go through to finally have it done?
To the large amount of weight I lost, I had some extra skin that I wasn't happy with, and I've decided to do my arms for an arm lift and have a tummy tuck done because I carried a lot of weight in my abdomen.
Sure. How did you decide on your surgeon?
I called here and asked for a list, and actually a friend of mine that had already had surgery had seen one of the doctors, Dr. Heineke, and that she recommended him. He was her favorite of the ones she had seen. So I went and had a consultation with him and was very impressed with his before and after pictures, and decided to have it done. I'm off during the summer, so I wanted to have it done and get ready to go back to work.
Good. Your friend Holly, she had a sleeve.
She did.
Thank you for sending her to me.
You're welcome.
She's doing great.
She is.
She might need plastic surgery eventually. She's doing so well.
She actually went with me to the consult, so
neat.
She could see if she was interested in that too.
So your upcoming plastic surgery, that's not something to take lightly.
No, I debated about it back and forth I'm still debating about it back and forth, but I guess I'm going to go through with it. My arms have a lot of excess skin underneath.
I am a receptionist for Dr. Dyer here at the office. I came to work here at the Center for the Treatment of Obesity for Dr. Dyer almost 2 years ago. My entire life I've struggled with my weight and never thought of surgery as an option for me. I worked here for a year before I finally decided to go through with the process. When I started, I weighed just over 300 pounds. It has always been an issue for me to be overweight, mostly being so young, mostly worried about my appearance and what other people thought. By the time I got to 300 pounds, it wasn't about my appearance anymore. My health was going. I couldn't walk around. I couldn't walk across the street to get something to drink. I couldn't walk up the stairs. I couldn't play with my son. And that was when I decided that it was time to do something. And July of 2012, Dr. Dyer performed gastric bypass surgery on me. I had a wonderful experience through the hospital and here at the office. I, since then, have lost 120 pounds and would not change my decision for anything in the world. My story. One of the life-changing moments, the first time I really started realizing that I had made the right decision, was a couple months ago. I took my son to the zoo. The last time I took my son to the zoo was a few months before I had my surgery, and we were there only a couple of hours, and I spent the entire day stopping and crying and out of breath. We ended up having to leave the zoo because I couldn't do it anymore. So 2 months ago, I took my little boy to the zoo by myself and spent the entire day with him with no problems. Best decision I ever made. I told you I was gonna cry. Oh, it's okay. I cry every time I tell that story, every time, but it's great.
Anything else you want to say or to people?
I know for a lot of people, and one of the reasons that I hesitated for a long time was I was worried that people would probably think I took the easy way out. And it's not easy, but it's definitely worth it. It was not the hardest thing I've ever done. It was a complete lifestyle change. But it is one that is completely worth it. And it makes your life and your worth and just you, it makes you better.
Well, I only had, at the time that I made the decision to do surgery, I only had one comorbidity, which is sleep apnea. It was pretty severe, but I wasn't diabetic, didn't have high blood pressure or anything like that. My wife had been on me to lose weight for the better part of our 12-year marriage at the time, and nothing had really seemed to work. We tried weight loss pills, we tried some exercise. I wasn't committed to it. Finally turned 50, went for my colonoscopy, and to weigh me in, they took me back to the loading dock and put me on the freight scale. So that was a nice little wake-up call. My general practitioner recommended that I come to a weight loss seminar. One of our neighbors happens to be one of the dietitians here, Pam, who recommended that I come to Dr. Olsen's seminar, and I did. Amy came with me, and process flew from there.
Great. And Amy, why did you decide to come here?
Well, about the same time he started his process, I went for my annual physical we share the same doctor, so to our general practitioner. He diagnosed me with hypertension. And I had also been curious about, since I'm now in menopause, don't I need to go to another doctor? And so he referred me to a gynecologist. She in turn diagnosed me with diabetes. This was all within a 2-week span. So I got hit pretty hard in the month of June and ended up going to the seminar with him as a support for him, only to hear that the procedure he was considering would take care of my diabetes. That the likelihood was so high that I would be foolish not to consider it.
Okay.
I was 100 pounds overweight, had 2 comorbidities, and that is what my insurance company required to meet qualifications.
All right, so I'm going to ask a general question here, and I'll let y'all, maybe you answer first and then you answer. I'm not going to call your name out. But let's talk about why you chose Centennial and Dr. Olsen. I know you talked about your next door neighbor, but was there other research that you did to figure it out, or did the seminar kind of tell you all you needed to know?
Well, we had done some research previously. We went to another facility in town to their seminar. Really wasn't happy with what we heard. It was more of a la carte type program, whereas the program at Centennial is all inclusive. And we felt like that was going to ensure our success in a better way than any of the other programs that we had checked out in town.
And to second what Amy said on that, like she said, it's an all-inclusive program, so you get to know the staff. They know you. You know the exercise physiologist. You really get to know the dietitians and the doctor staff. You get to know the surgeon. And the fact that it's on the same campus as the women's hospital where our surgery was held. We were just across the street from where the staff was. The nurses checked in on us. It was the fact that it was all inclusive and you got to know everybody right up before the surgery really made us comfortable with our decision to have the surgery here.
It makes us as patients not feel like patients, but feel like part of a family.
Yeah.
Like we can walk through this door, and it's okay here. You know, as heavy as we were, to walk through the door and nobody was judging us, nobody was being condescending. It wasn't, everything was geared towards us and our size, which was great.
That's terrific. So I know, and I'm just kind of talking some general stuff, and I'll let y'all tell it the way you want to, but I know you decided to have it together. So maybe let's talk a little bit about, maybe one of you say that, after coming to the seminar and making the decision, then we decided to do it together, and then y'all can kind of feed off of each other.
Well, we both chose Dr. Olsen. Rather independently, we chose Dr. Olsen. We'd come to the seminar, but I was pursuing bariatric surgery. Amy, at the time, was considering her options. So I talked to Dr. Olsen first and told him that my wife would probably be contacting him. And then when Amy came in, it's my understanding that he said, well, why don't you just do the surgery on the same day? It seemed like a novel approach to us. We'd be eating the same foods or not eating foods under the liquid diet, as it turned out. But we'd be progressing ideally at the same stage, the same process. We knew it was not a race to a competition. It was a support. We were in-house support for each other. But it just made real good sense to us. And the more that or the closer we got to our date of surgery, the more comfortable we really became with it. The fact that we were in the same hospital, we were just across the hall from each other in the hospital rooms. It was the best decision we could have made. And recovery post-op has just been phenomenal for both of us. We hold each other accountable. We hold each other support-wise. When one of us has a bad period, the weight loss, we hit a plateau or something like that, the other one's there to hold them on, and it's just been phenomenal. It's just been a gift from God from both of us.
Yeah, when we first decided to do this together, several family members wanted to do a sanity check on us, on both of us, because they said that wasn't right, that how were we going to take care of each other? And Dr. Olsen assured us that there is no taking care of you. You're fine. And he was right. I was extremely surprised about that. I was off of my pain meds the day of surgery and up walking, and I felt great. So there was no taking care of me. There was no taking care of him. we were doing just fine. Our family was extremely worried because we were doing this together, and I think after the fact they've seen that we really did make the right decision. And you know, like Glenn said, God put us in this direction. He put us in contact with Pam, who was a neighbor of ours and had been sort of coaching us for a couple of years that we really needed to come in and see her and see one of the doctors, and then Dr. Olsen was just a perfect fit for us, thankfully for both of us. And that doesn't happen very often, that one doctor fits the needs of both in the couples, but he holds us accountable and encourages us, and he is really invested in us.
That's a very good point.
And we never felt like that investment was to enrich his statistics as a physician, but he really was invested in us as people. And that's the feeling we get from everybody here.
To prove it even more so, to me, my recovery wasn't near as smooth as Amy's. As a matter of fact, I had a little bit of a difficult period a couple of days post-op. And when I came home from the hospital, Dr. Olsen personally phoned our house to check on me and Amy.
For 3 days.
For 3 days when we came home. So we came home from the hospital the day of Thanksgiving, which was a little strange. Everywhere we looked on the TV was food, 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 and we didn't want anything to do with it. But I mean, Dr. Olsen personally called us morning, noon, and night for 3 days during that holiday period to check on us to make sure we were doing okay.
What a great story. What a great story.
Yeah.
So, and I know you've probably already said this, because I know your experience has been great. I can tell by looking at you. You kind of talked a little bit about the staff and what have you, and how they're kind of like a family unit and what have you. Let's maybe expand a little bit more on that, because this is going to be maybe have a twofold thing that we're doing here.
Okay.
You know, when you guys get home and get a chance to see our show that I gave you my card for, you'll see the actual segments that we produce for Centennial, where the doctor is talking about a patient and the patients are talking about the doctor. So we put those together. So we're going to try to do that with Dr. Olsen. So let's talk a little bit about your experience here at Centennial. How the staff was, from the day you came for the first, and we'll keep it kind of brief because I know y'all done a lot of this in this right now. You came for the consult, staff was great. Dr. Olsen was great. We would recommend that if anyone needs to have something done about the problem of obesity, to come see Centennial and Dr. Olsen. Something along those lines. Kind of like ending with a testimonial to him.
Sure.
Y'all talked about it.
Go ahead.
in
I'll
great
follow
way.
You go first.
Me first?
Please.
Okay.
Go.
When we first came to the seminar with Dr. Olsen, and they had a few of the other staff members that were there, they not only gave us the information, John, but they took all of our information. I mentioned your name.
I didn't mean to do it. Yeah. You've done great up to this point.
But the
Don't
conversation
mention me, 'cause
part.
nobody will know
Yeah.
that I'm interviewing you. They'll just think you're having a conversation.
The conversation part kind of flipped me a
There
bit.
you
All
go.
right. When we first came to the seminar at Centennial, Dr. Olsen was great with his presentation. It was very just, here are the facts, here's what we can do. He made no guarantees or promises or anything like that. He said, but this is what the facts support and this is what our results have supported. He just laid it out there. Staff members were there to take our information and to begin the process for insurance clearance immediately. It didn't have to wait any time. It's just the process, the ball rolls from that first day. And then as you come in for your consultations with the physicians, with the nutritionists, with the exercise physiologists, and with the psychologists, the ball just keeps rolling. It just keeps rolling. And you don't, there are no dead periods during this. You just get the immediate support, and they work you on the program, even pre-surgery, to make sure that you are in the best shape possible for your post-op recovery. And then they have the rehab facility here on campus where you get a discount at the gym there to work with the exercise physiologists all during the times that you're there. And it's 3 days a week minimum, and you just get the best care. We did the exercise physiologist here on campus for the first 2 months post-op, and then we moved to a gym closer to our home where we can go 5 days a week. We still check in with a fixed exercise physiologist to make sure that there are new exercises that we can add as our body heals to increase and enhance our weight loss, but to also to increase and enhance our body tone. You know, losing the pounds is one thing, but to actually increase your body tone so that you feel better about yourself, you look better to yourself, to your spouse, to other people, to actually feel and look as good to yourself in the mirror as you possibly can. This program covers the whole spectrum, and it's not just about the surgery. It's about your lifestyle.
The surgery is only a tool. That's it.
Exactly.
Just like your scale at home is a tool, and just like your blender that you mix your food is a tool, and the treadmill is a tool. This surgery is just a tool. That's it. And you can abuse a tool. Many people have. But with the tool, it makes using these other tools a lot easier. I've noticed that, people say to me, oh, this must have been really difficult for you. And in some ways, it's been difficult, but in some ways, it's been very easy. It's like a weight's been taken off of me, excuse the pun, but a weight has been taken off my shoulders where, although I still have to make wise decisions about my diet and exercise, in some ways, I don't have a choice. If I don't eat my protein every day, I feel weak. If I don't exercise, I feel like a slug. And so I don't really have a choice in that. And that's what makes it easy, is I don't have a choice. If I want to feel good, I have to do these things on a daily basis. It's every single day. My feet hit the floor in the morning, it's a new day, a new decision to make. I go to bed that night, and I can feel good that for that 24-hour period I did what I was supposed to do. And the next day I work on another 24-hour period.
That's terrific, terrific. I want to end it with this. One of you, it doesn't matter which one of you, we want to give just a quick testimonial that says, if you have the need for a bariatric surgeon, or how would you want to phrase this for
if you're thinking about bariatric surgery, we would definitely encourage you to consider Centennial.
And what I'd like for you to do, because y'all been doing this very well through this, one of you say it, but kind of be looking at each other like we both agree. You kind of got that look. So it doesn't matter which one of you does that, but I want to end it because you all have a great story and you tell it well. So I just want to kind of end it with, come see these guys, however you really want to say that. But just one of you say it. Maybe at the end, the other one could go, I totally agree. Something like that, so you don't both go through it, because we want to make this short.
Sure.
Yeah. For us, as a couple, the bariatric surgery that we experienced, that we went through, added what we believe to be years to our life, and it cured her diabetes, it cured her hypertension, and it is curing my sleep apnea. It is adding quality years to our life. If you're remotely considering the slightest possibility of bariatric surgery, please don't hesitate. Find a seminar that is offered here at the Centennial Center for Obesity. Come hear what they have to say. Come hear their program. Talk to the people on staff. Do your research, get your facts, but do it, and do it now.
I totally agree. Best choice we ever made.
So the seminar has been an overview of what to expect with weight loss surgery as far as obesity and its impact on your health, and what bariatric surgery can do to improve those things. After the seminar, usually what happens is you get plugged into one of our financial counselors, and they start to work with you to help you meet your insurance criteria to get the surgery approved. And then once they're moving down that pathway, you'll then come into the office and have a consultation with one of us. At that point, we do spend about an hour with you going over in more detail these procedures and what to expect and its complications. We will try to help you decide on which procedure to choose if you haven't decided already. We do like for you to do a lot of research on your own into these procedures to really see which one might fit you best. And then from there, there's a class that you attend a couple weeks before surgery. It's about half a day, and you'll see the dietitian, our program director, and they go over just other things to expect getting ready for surgery. You have some testing done from anesthesia, and then we have surgery. And really, it's a pretty streamlined process. We feel like we've tried to make it as easy as possible for you all to get from here to surgery.
Thank you so much for taking the time to watch our online seminar today. Your next step in your Centennial experience is to contact us at 615-342-1231. Let us check your insurance benefits. Let us walk you through all of the next steps for surgery and make sure that we have everything we need to get you approved. I don't like that at all. Thank you so much for taking the time to watch our online seminar today. The next step to get you ready for surgery is for you to give us a call at 615-342-1231. At that time, we'll connect you with one of our insurance specialists. We'll go over all of your insurance criteria and make sure that we have everything in place for you to be approved by your insurance company. If you choose not to go through your insurance, or maybe they just don't follow surgery, or maybe they just don't cover surgery, we have multiple self-pay options available for you. We'll be happy to discuss that with you. There are several of us here that are bariatric surgery patients, so we're always available to answer your questions on a personal level as well as a professional level. Again, thank you so much for your time, and just give us a call, 615-342-1231.